Welcome everyone to today's endocrinology grand rounds. We are very happy to have Dr. Elizabeth Bruenderman from the Department of Surgery to talk to us about bariatric surgery. Dr. Bruenderman is um, not new to us. She did her, undergraduate education at the University of Louisville, went to medical school, graduated in 2016, did her residency in surgery here before going to Duke to do a fellowship in advanced surgery. She has been board certified in surgery and is also board certified in obesity medicine. She has been the medical director of the Advanced Bariatric Surgery and Weight Loss Program here at the University of Louisville. And as the title of her talk itself shows you, that she's getting back University of Louisville on the track to again becoming, very proficient in bariatric surgery. During her residency, she won numerous awards, including the Gerald Larson Award, Evelyn Hagen Award, Pediatric Surgery Award, Waterman Abrams Award, and the Ashley Wilson Award. Looks like she got all the awards that were there in surgery. She has worked hard over the last couple of years to develop this program in bariatric surgery. And it is really important for us at this juncture to learn a bit more as we have, with the introduction of the GLP-1 analogs and upcoming other newer medications, the incretin mimetics, that there are certain options that we have, and we look forward to seeing how to incorporate the different approaches to bariatric medicine and surgery to get the best outcomes to our patients. So we look forward to hearing from Dr. Bruenderman. Dr. Bruenderman?
Thank you very much. Thank you. I'm very excited and honored to be here, to be invited to talk to you guys today. Hopefully you can appreciate the play on words on my slide here, the power of Rue, the power of you, Roux-en-Y gastric bypass. That's what I was going for, so hopefully you got that. But I have no disclosures. My goal here today, I actually have a number of goals. I'll talk briefly about the current state and the scope of the obesity epidemic, analyze current treatment options, and I understand my audience. I'm used to speaking to surgeons, and you guys are going to know a lot more about obesity and medical treatment options than my usual audience. So this talk is going to be very focused on the surgical options, so you can understand kind of what I do in my world and how our worlds can combine. And then I want to talk about the future of obesity management. And as kind of an overarching theme, I do want to advertise the services here. So U of L hasn't had a true bariatric surgery kind of program as we think about it now pretty much ever, but there hasn't been anyone doing bariatric surgery here for about the past 10 years or so. A lot has changed since then. It's really a rapidly changing field. We have evolved greatly in the safety and quality of surgeries. There's been a rapid rise and fall of certain surgical treatments. We've introduced very effective medical treatments that we've never had before. We have an evolving understanding of obesity mechanisms, and there have been really complex cultural revolutions surrounding weight and body image over the past 5 to 10 years. And so my goal is to highlight these changes as well. To start, we'll just kind of get a blank slate with definitions. Obesity is abnormal or excessive fat accumulation that presents a risk to health. And it's classified by BMI, as we all know. Overweight, BMI is greater than 25. Class 1 obesity is greater than 30, Class 2 greater than 35, and Class 3 is greater than 40. I'm sure everyone in the room knows this, but I say this to highlight that the terms morbid obesity and super obesity, or super morbid or super obesity, whatever you want to call it, is no longer used. There's really been a strong push to kind of veer away from those terms that have these negative connotations. The term overweight and the term obese is no longer an accepted use as an adjective. So if you submit an abstract to the American Society of Metabolic and Bariatric Surgery and you use the term obese as an adjective, your abstract will be sent back to you. So these are kind of some of the cultural changes that we're seeing surrounding these terms. And if, as a side note, now that we have kind of the My Chart system and patients can see their notes, when they see these words written in their chart, that's really hard for a patient to see super morbid obesity. It's not kind of the message that we're trying to send. So where did we start with all of this? When did this become a problem? Really kind of this started taking shape in the early 1950s. And this is when there became a concern over the fitness of American men to serve in the military, specifically around the time of the Korean War. In 1955, a study, the Krauss-Weber Physical Fitness Report, came out, and this compared the fitness of children in the US to the fitness of children in Europe. And the children in the US failed miserably, 58% failure versus 9% failure for European children. So this sparked some kind of programs at the federal level. In 1960, JFK published an article in Sports Illustrated called The Soft American. And in this, he really tried to push this idea. You can see the quote here: "The physical vigor of our citizens is one of America's most precious resources. If we waste and neglect this resource, we will be unable to realize our full potential as a nation." So he started a lot of federal programs to improve the fitness of America's youth and really garner enthusiasm for this nationwide. At this time, a fitness song came out that children in schools would work out to, called Chicken Fat, and the lyrics were, "Go you chicken fat, go away, once more on the rise, nuts to the flabby guys." So a really unhinged time, if you ask me, but that's where it began. And now this is where it's gotten us, pretty much nowhere. This map is shown in any talk you will ever seen about obesity, so I won't harp on it, but the thing that I want to point out is this in the red circle here. The number of states with adult obesity rates above 35% in 2011 was 0. In 2021, 10 years later, that's 19. The rise is rapid in the country, or in the United States, and really worldwide. So that's what I want to point out with this. This is a problem that continues to perpetuate itself. So why is this a problem? The health impacts of obesity are far-reaching. These are the top 10 leading causes of death in the United States in 2022, and pretty much all of them are either caused by or exacerbated by excess weight. It affects every organ in the body. This is not an exhaustive list, and you can see how long it is. And the thing that's concerning is the risk effects seem to increase without a clear plateau. So the more fat mass you have, the greater your severity of illness with no end. The personal impact of obesity is immensely far-reaching. We're talking about reproductive impacts with both male and female infertility, economic impacts. People have been shown to have less educational advancement, make lower wages, have greater rates of unemployment, costs of clothing, healthcare, pretty much everything you do in life, and that's only to name a few. Quality of life is significantly impacted. People have trouble traveling, if they can travel at all, low energy, poor mobility, poor sleep, difficulty finding clothes, really significant limitations on life, and they have significant impacts on a patient's self-esteem. There's significant weight bias and stigma in our culture. People feel embarrassed. They feel like they're failures. And people who I see in my clinic think about their weight every single day of their lives. It is their number one thought when they wake up in the morning and their number one thought when they go to bed. And that tugs at my heartstrings. And that's the reason that I do what I do, because I want people's lives to be changed in that manner. But even if you don't care about that at all, obesity is costly. Indirect costs, in terms of employers and workers, it's $425 billion annually in the United States, and that's only direct costs. The indirect costs are also in the billions. So this is a very costly disease for us as a nation. So it's simple, right? How do we solve this problem? We're eating more, we're moving less, calories in, calories out. If calories are greater than in or greater than calories out, then you have obesity. In 1974, this article came out in The Lancet. Most obesity could, with care, be prevented. So if we've known this since 1974, why is this still a problem? It's because it's not that simple, right? So I love this diagram here. There's no way you could possibly read what's in it, but it shows you how complex the mechanisms are for weight homeostasis. It's just this intertwined world that ends up with energy balance in the middle. And if you look at these general categories, you can see that only two of them are within an individual's control. Food consumption, so that's our calories in, and individual physical activity, that's our calories out. Everything else, consider the physical activity environment. If you live in a dangerous neighborhood, you're not getting out and walking your dog, walking with your family at night. It's too dangerous to do that. Food production, we have absolutely no control over our food supply and what's put in our food. So these are the types of factors that all go into energy balance. So a much, much more complex system than calories in, calories out. There are complex neural controls. This study, I think this study is pretty remarkable. So this came out in 2007 and compared rats' propensity to choose either sugar or cocaine. And guess which one they chose? Sugar. That's really a hell of a statement that mice preferred sugar over cocaine. So really, really strong, intense neural control over appetite. Losing weight is really hard. Maintaining weight loss, which is a completely different physiologic mechanism, is even harder. You can't just give up food, right? It's not like alcohol. We can't just stop it and say, all right, we're done with that. It has a complex cultural context as well. And lifestyle changes cost money and take time. There's minimal insurance coverage for nutritional counseling or diet and exercise programs. So we're really setting people up for failure here. There was a study that came out. Does everyone know what The Biggest Loser is? The TV show where they put people on extreme diets, workout, lifestyle changes, and most people lose a significant amount of weight. So this study looked at what happened at 6 years later. Every single person but one had gained weight back at 6 years, 5 of them to above their starting weight. So these are people who know the lifestyle changes, implemented the lifestyle changes, and still couldn't keep the weight off. So what's the reason for this? Well, leptin levels plummeted with weight loss surgery and with their weight loss. And they had metabolic adaptation. So their resting metabolic rate declined with weight loss at a rate that was disproportionate to what they would be expected at that weight. So they're burning fewer calories and they feel more hungry with their weight loss. And this kind of points to a theory that's out there called set point or defended fat mass, which is essentially that a person's body is programmed to stay within a certain weight range, and that if you gain weight or lose weight, your body will program you to go back to whatever that weight range is. That's more of a theory than a proven type of phenomenon. So with an increased understanding of how complex these mechanisms are, there's been a strong push away from obesity being simply a condition of willpower. There has been a strong push to standardize language defining obesity as a chronic disease with an effort to increase insurance recognition and treatment coverage for the treatment of obesity. There's been a strong push nationwide for the body positivity movement led by Lizzo, if you're into pop culture, a lot of reality shows around her dancers, etc., things of that nature. And then there's been a strong push to reduce stigma. So we recognize in the context of other health conditions like HIV or mental illness that stigma is detrimental to the treatment of these patients. But for obesity, for decades, we've somehow thought that creating stigma around it is motivating, and that doesn't really jive. And clinicians are some of the worst culprits of this. So you can see the past president of the Association of American Physicians and Surgeons in 2020 said, let's confront the elephant in the room. Healthcare policy should promote personal responsibility rather than encourage free riders. In America, we're free to overeat and under-exercise, but we have no right to make innocent bystanders pay for the consequences. This is a leader in healthcare who's saying this. So we really are some of the worst culprits here. And we have studies that show that this is detrimental. So everyday discrimination in a racially diverse sample of patients with obesity, weight discrimination was higher than race, gender, age, sexual orientation, religion, and then everything else in this other category. So this is significant and something that we are really perpetuating oftentimes as clinicians. So what's the bottom line? And I put this slide on here because I work in a department of surgery with a lot of people who really still believe in calories in and calories out. And I think there are many people in the healthcare system who believe this as well. But we don't question treatment for any other condition that's, quote, caused by the patient. So heart disease that requires stents or a CABG, liver transplant from alcoholism, some traumas that we see. So why are we questioning it with obesity? The downstream impact of treating this one condition can be astronomical for a person in terms of their health and their quality of life. We dramatically change people's lives with treating this one condition. So as a provider, it doesn't matter if you believe that obesity is a biological process or simply a condition of willpower. It doesn't matter what you think about that. What does matter is that you accept reality. Whether people cannot or will not, telling people to eat less and exercise more simply doesn't work. We've proven that over the course of decades. So if we really want to help people as physicians, then we need to do a lot more. So what are our options? Again, I'm going to focus on surgical treatments. I'll discuss briefly endoscopic treatments. I know Dr. Liu had a grand rounds for you guys about a year ago about that, so I'll touch on that briefly. And then the medical treatments will be very brief. Again, I'm preaching to people who know way more about those than I do. So a little bit of history on bariatric surgery. First of all, it has it's termed now metabolic and bariatric surgery. That's kind of the new terminology around it, and it has a rocky past. So it was initially developed out of observations of weight loss after GI surgeries that involved gastric and bowel resections for other problems, trauma, and other general surgical problems. But bariatric surgeons in the early years were really seen as renegade surgeons who were treating a condition of gluttony and sloth and wasting healthcare resources. But in the late 80s to early 2000s, there was a growing insurance coverage for bariatric surgery. So a lot of surgeons who had absolutely no bariatric training started to perform these surgeries, and they had increased complications, which further kind of made this a renegade field in surgery. And then it led to a drop in insurance benefits. So since that time, there's been a very strong push to legitimize bariatric surgery and improve quality outcomes. And that's included research initiatives, minimally invasive techniques. So laparoscopy revolutionized this field of surgery in terms of its safety. And then there's been a growth of the American Society of Metabolic and Bariatric Surgery, the ASMBS, which is the most prominent bariatric society in the United States. And they really set the standards for quality in bariatric surgery. They combined with the American College of Surgeons in 2012 to come up with the MBSA-QIP registry, which is similar to the NISQIP registry for surgery. And they developed an accreditation pathway for bariatric centers with strict quality metrics. They formalized educational and training standards, developed consensus guidelines and integrated health protocols for multidisciplinary care, and they've advocated for access to care. So where do we stand today with bariatric surgery? A lot of surgeons have trouble kind of overcoming the idea that we're attempting to treat a physiologic process by altering anatomy. And that's hard to kind of wrap your head around, I think. But we know that it is the most effective and durable treatment for obesity that we have even today in 2024. It reduces the risk of premature death by 30 to 50%. It's safe. It has a mortality rate of 0.1%, which is as safe or better than getting your gallbladder removed. Risk of major complication is 4%. But I approach this knowing that bariatric surgery is always elective. It is always voluntary. So if we are going to do this, we better get it right. I'm going to review the ASMBS endorsed surgical treatments, and I've kind of nicknamed all of them here. So the most common is the vertical sleeve gastrectomy. Old faithful, been around forever, Roux-en-Y gastric bypass. Promising newcomer, single anastomosis duodenal ileal bypass with sleeve, or SADI, SADI-S. I will shorten it to SADI. Making a comeback. Some people cringe when they hear me say this. Biliopancreatic diversion with duodenal switch. Newest addition with a sordid past. I'll get into this, but that's the one anastomosis gastric bypass. And then not gone, not forgotten, adjustable gastric band. Vertical sleeve, again, the most common. Brief history, it was developed out of the duodenal switch. So this is step one in a duodenal switch. And it was developed out of that in the early 2000s because people started getting the duodenal switch as a staged procedure to make it easier to do the more difficult dissection once they had already lost weight. So they were noting that just with the sleeve, people were losing a significant amount of weight, and that's when it became a standalone procedure in the surgery. And feel free to stop me if you have questions or are confused, because some of these can get into the weeds. But in the sleeve, you resect the greater curvature of the stomach. So about 80% of the stomach gets stapled off and removed forever. So what you're left with is this kind of banana or, quote, sleeve shaped stomach. It has two mechanisms. One is restriction, and then one is metabolic via the mechanism of decreased ghrelin, so decreased hunger. The surgery is fast. It has no bowel involvement, minimal malabsorption, no risk of marginal ulcer, and there are a slew of revision options for people who come back who have inadequate weight loss or have weight regain. The downsides, short term. If you have a leak along this staple line, that is a major problem that does not have a simple solution. So that's going to dominate someone's life for probably the next year if they have a leak. Not a good answer to that problem. And then long-term, the biggest problem that we see after a sleeve is acid reflux. And that's up to 30% de novo reflux, people who didn't have reflux before the surgery, who developed reflux after the surgery. Previously, the most common revision operation in bariatric surgery was a band removal, but now the most common revision is a sleeve conversion to a Roux-en-Y gastric bypass because of postoperative reflux. The concern, of course, being the potential development of Barrett's esophagus and esophageal cancer down the line. It's not reversible, and it has the least metabolic effect of all of the surgeries, well, less metabolic effect of some of the newer surgeries. Contraindications. So these are my contraindications, and every surgeon is going to have their own set of rules for who they will and will not do these surgeries on. But all of mine are reflux related. So if you have a large hiatal hernia or LA grade C or D esophagitis, this is not the surgery that I'm going to offer you. The jury is still out on whether or not Demeester score preoperatively correlates with an increased risk postoperatively, and then a prior lap band. So that's a contraindication for me. There are plenty of people who will do a sleeve after you've had a lap band, but because of the scarring right around the GE junction and the fundus, that's going to increase your likelihood to being very likely to have reflux after this surgery. It's ideal for people who have a high marginal ulcer risk who you do not want to do a bypass on. People who rely on precise medication absorption. So someone who has severe bipolar disorder, some sort of significant psychiatric history, I will think, or this is the surgery that I would suggest for them. People who have hernias that contain bowel, and people who have any kind of significant surgical or medical history that's going to lead to a lot of scar tissue and adhesions that's going to make any other surgery difficult. Yes?
Gotcha.
So in terms of resolution, gastroparesis is actually, this is considered a treatment for gastroparesis. And I am much more likely to do a sleeve on someone with gastroparesis than a bypass because I worry about the remnant stomach and the bypass leading to bloating symptoms, particularly if those are their predominant symptoms that they feel. But this, in theory, changes the velocity of how foods and liquids move through your stomach to actually increase gastric emptying. And then in terms of diabetes, we'll get into that in a little bit. Okay. So the bypass, we've been doing this for over 50 years and have had a continued evolution through that time. In this surgery, we create a small gastric pouch that's separated from the gastric remnant. Nothing gets removed in this surgery. Everything just gets rerouted. We do a kind of this Roux-en-Y configuration where we separate the biliopancreatic limb with the digestive enzymes from the alimentary canal here. So you have malabsorption in this limb. It has three mechanisms: restriction with how much patients can eat. This pouch is about the size of a hard-boiled egg. Malabsorption, they have no absorption for the length of the roux limb. So that's where you can play around with kind of how malabsorptive of an effect the surgery has. And then there's a metabolic effect. So this surgery will lead to a skyrocketing of a patient's production of GLP-1. It will increase leptin and decrease ghrelin. Greater weight loss with this surgery than with the sleeve, greater effect on diabetes and other conditions, and it is a treatment for acid reflux. Cons, lifelong risk of a marginal ulcer. So this is the Achilles heel of the gastric bypass. It's an ulcer that develops between the stomach and the small bowel connection. Risk factors for that are NSAIDs, steroids, and smoking. So anyone who has any of those things or is reliant upon them, I will steer them far away from this surgery because that can be a really, really bad problem. Dumping syndrome, which is low blood sugar if you eat carbohydrates, and then you have diarrhea. Internal hernia and bowel obstruction are risks after this, nutrient deficiencies and malabsorption. And then you lose access to your bile duct. So if someone ends up having choledocholithiasis, you have to get kind of fancy if you want to do an ERCP on them. Contraindications, marginal ulcer risk factors, need for precise medication absorption. So I will hesitate if someone has a significant psychiatric history and steer them away from this surgery. People have bowel containing hernias that can make this surgery really difficult and increase your likelihood of having a bowel obstruction after surgery that can cause you problems. And then anyone who has need for frequent bile duct access, so if they have a history of pancreatitis and needle stent exchanges, et cetera, this isn't the surgery for them. It's ideal for people who have acid reflux. So if you have a hiatal hernia with acid reflux and your BMI is greater than 35, this is the surgery that I'm recommending to you as opposed to a formal hiatal hernia repair. So people with diabetes, the benefit diminishes if you've been on insulin for greater than 10 years. So that's where I'll counsel people. If someone has diabetes and they've been on insulin for less than 10 years and are otherwise good candidates, I will steer them toward this surgery every day. But that's where I kind of veer off. If it's been that long, I'll say, okay, well, we don't know. It's just going to depend on how well your pancreas is still functioning. People who need greater weight loss, and then people who have had bands in the past, this is the surgery I will do on them. The reason being, again, we talked about the reflux risk with the sleeve, but where I make this pouch, I can basically staple all around the scar tissue where their band will have been, and that's as opposed to a sleeve where I have to staple through their scar tissue. That's going to increase their risk of leak as well. Okay, the SADS, this is our newcomer. It's been around for about 7 to 10 years. It was an established procedure with the IFSO, which is the International Bariatric Surgery Organization, in 2018. Step 1 is the sleeve, and step 2 is a bypass, but it's different from the gastric bypass. So where you make your transection is the first part of the duodenum, and you attach the D1 to a distal loop of small intestine. So you only have one anastomosis, and you still have your pylorus, and you are doing a small bowel to small bowel anastomosis. So all of these things come into play when we talk about this compared to the gastric bypass. Mechanisms are restriction, moderate malabsorption, so it's going to be more than the gastric bypass, but less than the duodenal switch, and then the same metabolic effects as the gastric bypass. Really great weight loss with this surgery, and we'll compare all of these side by side in a bit. Low risk of marginal ulcer, that's because you have a small intestine to a small intestine anastomosis. Low risk of dumping syndrome, that's because you maintain your pylorus and you have slower emptying into the small bowel. You have one anastomosis, so that's fewer places for a potential leak, and you have less nutrient risk as compared to this surgery's brother, which is the duodenal switch. Cons, limited insurance coverage. So there are only a few insurances in Kentucky that are covering this right now. UofL Health Insurance is one of them, if you have a patient who's interested in this. Limited long-term data because it's so new, higher risk of nutrient deficiency than a bypass. You still have your risk of internal hernias and bowel obstructions. Contraindications. I get concerned if someone has a history of non-compliance, not showing up to their appointments. I worry about their risk of severe micronutrient deficiencies and not taking their vitamins correctly after surgery. People who have bowel-containing hernias, and again, people who need frequent bile duct access. They're ideal for people who need significant weight loss but are not candidates for a bypass due to a marginal ulcer risk. The duodenal switch. This came about in about 1988 as a response to the marginal ulcer dumping syndrome problem from the bypass. And there's been an evolution over time of the limb lengths. So how malabsorptive we make this procedure. And that's in order to promote the safety. So when this surgery first came about, people were dying after this surgery because their intestinal or their absorptive length of their intestine, also called their common channel, was only about 50 centimeters. And that's just not compatible with life. So that number has been moved back. The standard is about 150 to 200 centimeters now of absorptive capacity. So it is a little bit more safe and done a lot more frequently now. But it's a sleeve plus a Roux-en-Y configuration of a bypass. So whereas your Sadie had this loop, you transect right here before your loop and bring this limb all the way down here, just next to your ileocecal valve right here. Best weight loss of all the surgeries, best resolution of comorbidities, low marginal ulcer risk. But you do have a high risk of severe life-altering, life-threatening vitamin and nutrient deficiencies, as well as frequent diarrhea. So in my fellowship, some of my attendings would give patients orlistat preoperatively, so they would have an idea of what their life was going to be like after the duodenal switch in terms of the number of bowel movements they were going to have in a day. Contraindications: if you do not have a reliable patient, you cannot do this surgery on them. Bowel-containing hernias, again, need for precise medication absorption. Ideal for a very reliable patient who needs a lot of weight loss, or as a staged procedure if someone's had a sleeve, had a Sadie, and haven't had the weight loss that they wanted. So the one anastomosis gastric bypass is very new. Well, okay, I take that back. It's not new, but it was only recently endorsed by the Bariatric societies, the IFSO in 2018 and the ASMBS in 2022. And it does have a sorted pass. So this surgery, to tell you a little bit of an entertaining story, started to be done in North Carolina in the early 2000s by a trauma surgeon there, who noticed that people had surgeries for gastric ulcers and had kind of this B2 Billroth 2 configuration would lose weight. So he came up with this surgery and started doing it. It's a little bit different than the gastric bypass. You do have a gastric pouch here. It's longer and more narrow than in the standard gastric bypass. And then you bring a loop of small intestine up. So it's similar to a Sadie, but the connection is between the stomach and the small intestine. And the surgeon who started doing this didn't necessarily follow the protocols that we follow today. And there was this kind of, if you had a surgery by this surgeon and you saw someone else out in public who had also had a surgery by this surgeon, the thing you would say to each other is, oh, how fast was your surgery done? And you would compare, and that was the mark of a good surgery. So it was, oh, mine was done in 18 minutes. Oh, well, mine was done in 17 minutes. And the surgeon would go through the surgery and then he'd say, done. And they would time it. And so that was the mark of a good surgery. So you can see where this, maybe wasn't done kind of in the way that we would hope that it would be done. And over the course of time, many people started showing up with all sorts of complications. That surgeon lost his license in the United States and then it sort of became a traveling show and would show up in Las Vegas one weekend and show up all over the United States teaching surgeons how to do this. And oh, this famous doctor. And then he ended up losing his license in the United States entirely and then took this to Europe. And in Europe, it actually kind of took off. So they've been doing this surgery in Europe for decades and really have accumulated very high quality data to show that it's actually safe and has good outcomes, and maybe even, rivals or surpasses the traditional gastric bypass in some areas. But because of this pass that it's had in the United States, it's only been accepted only recently. But this is potentially a very good option for some people. It is fast. It's only one anastomosis, so a lower leak rate. Some studies show that it might even have better weight loss than a standard gastric bypass. It's at least as good as a gastric bypass. And there's some studies that show it has potentially less marginal ulcer risk. So kind of an interesting development, very limited insurance coverage in the United States. The outcomes here, as I said, historically are not good. There is the concern for bile reflux, and that's what everyone who looks at this will think. This is your biliopancreatic limb here coming up, and so you potentially have bile reflux up into your gastric pouch. But again, the data in Europe show that that's not any higher than what you would see otherwise. There's a lower resolution of acid reflux than with the gastric bypass, and you still do have a marginal ulcer risk even if it's lower. We don't really know the indications and contraindications for this yet. It's still developing. Finally, the adjustable gastric band. This really had its heyday in the 1990s and early 2000s, along with frosted tips. But it's still done very frequently in certain parts of the United States, Louisville being one of them. So it's an adjustable silicone band that's placed around the superior portion of your stomach. It's attached to this port here, which extends out. There's a subcutaneous port that's placed under your skin, typically near the belly button, that's accessed with a needle to inflate and deflate the band. The mechanism is restriction only. Pros, it's adjustable, so you can get weight loss beyond 1 year. That's compared to the other bariatric surgeries, which you're going to see your weight loss happen in the first year to year and a half, and beyond that, you're not going to see any more weight loss. So it is something that you can use as a tool for as long as you have the band in. It is removable and you don't alter your anatomy, which a lot of patients like that idea. But it is a foreign body. It can slip, it can erode, it can obstruct, it can strangulate. People have to have frequent needle sticks, which is unpleasant. It can cause regurgitation, vomiting, reflux, damage to the esophagus. You can have port infections, port can flip. And all of these complications really with modest weight loss. So this is the lowest, you're going to see the lowest weight loss with this surgery of all of the surgeries. 50% of these get removed at 10 years for one reason or another. So I don't think they are the best tool that we have in 2024. They are still being used, but I would encourage you to kind of expand your horizons and think about some of the other surgeries that have better outcomes than this. Contraindications, anyone with esophagitis or esophageal motility disorders, some would argue anyone. Some would argue this surgery should not be done anymore. It is ideal for people who don't want alteration of their anatomy. So looking at these side by side, again, majority of the weight loss is going to occur in the first 12 to 18 months post-op. And bariatric surgeons talk about weight loss in terms of the percent of your excess body weight loss. So actual body weight minus ideal body weight, the percentage of that, we typically aim for around 70%. But you can see with the band, excess body weight is going to be this blue bar here, and then total body weight is going to be the gray bar. But with the band, you're only getting 30 to 50% of your excess body weight. Sleeve is going to be around 60 to 70, bypass 60 to 75. The duodenal switch and the SATI are going to be 80 to 90% of your excess body weight at a year to a year and a half. So this is one of the major studies that came out within the past couple of years, and this is comparing the sleeve to the bypass 10-year outcomes. The differences were found in percent excess body weight loss, so that was significantly more with the bypass, and percent resolution with hypertension. But there was no difference in remission of diabetes, dyslipidemia, or obstructive sleep apnea. So that's a really interesting study that came out recently comparing those two. Also, this study was the first one to look at reflux outcomes between the two. And there was a higher rate of reflux with the sleeve versus the bypass, but there was no difference in progression to Barrett's esophagus at 10 years. So that's really been the big question on everyone's mind of, is this reflux going to make a difference long term? Yeah.
Is the 10-year outcome standard in the surgical? Well, so, and like when they look at the amount of weight loss and compare it, they always just do it at 10 years?
No, 1 year, 3 year, 5 year, 10 year. But okay. So the reason this is interesting is because this is the first time, because the sleeve has only been around since about 2010. So we're only now getting long-term data with the sleeve. Yeah, yeah. So there's a pretty significant preoperative pathway that patients have to go through to get approved for surgery through their insurance company. So basically you have to use the term proof of medical necessity, BMI greater than 40 or a BMI greater than 35 with an obesity-related comorbidity. These numbers are knocked down a little bit if you are of Asian ethnicity. IFSO did update their guidelines in 2022 to recommend a reduction in the BMI requirement to a BMI greater than 35 or a BMI greater than 30 with a comorbidity. I don't know that many insurance companies have started to come around to this yet. You have to document past participation in a weight loss program, medical and mental health evaluations, nutrition evaluation and education. You have to educate the patient on surgical risks, expectations, need for lifelong, long-term follow-up, as well as lifestyle changes. This is the pathway that I put patients through. It's pretty extensive, a whole slew of labs, chest x-ray, smoking cessation. Most insurance companies will require a 6-week minimum. I require a 1-year minimum for smoking and 6 months for vaping. The risk of death around surgery is 5 times higher if you're a smoker. So I want that to be well in the past for the patient. Nutrition evaluation, psychology, cardiology, sleep study, if their stop bang is would dictate that. I do an upper endoscopy on all of my patients to make sure there's no contraindication to surgery. I require that all of their standard medical screenings to be up to date, and then others will be based on an individual patient's own medical problems. There are surgical ERAS protocols, so enhanced recovery after surgery. We work very hard to limit DVT risk. So every patient's going to get Lovenox before, during, and after the surgery. Some will go home on Lovenox as well. We limit narcotics. Most of my patients do not go home on narcotics. Aggressive nausea control. There's minimal to no period of NPO, so that's different. We used to keep people NPO. We used to get an upper GI. They would stay in the hospital multiple days. Now people get to drink right after surgery. They go home on full liquids. They'll go home the day after surgery or 2 days after surgery. So they're really in and out. There is an increasing move to make bariatric surgery outpatient, and there's really evolving literature on the safety of this. But in 2023, the CMS tried to make this an outpatient procedure for all of their patients, which is really kind of incredible because those patients are going to be the ones who need to be in the hospital the most. And there was a really strong push from the bariatric community to stop that movement. And we did that successfully, but that is coming down the line, bariatric surgery as outpatient surgery. The perioperative diet is going to vary between different practices. I have them on a low carbohydrate diet for 3 weeks before the surgery. Clear liquids is 2 days before the surgery. They're on full liquids and pureed foods for 1 to 2 weeks, or for weeks 1 and 2 after surgery, soft foods at week 3, and regular textured foods at week 4. So a slow diet progression. And we emphasize protein, getting at least 70 grams daily and 64 ounces of fluids daily to prevent dehydration. So moving on to endoscopic treatments, the endoscopic sleeve gastroplasty is kind of the newcomer here, which has shown good weight loss, 45% of excess body weight versus 13% control at 1 year, 25% at 2 years, limited long-term data. So we really don't have much data past 2 to 3 years on this. It's going to be less weight loss than any of the other surgical options, but this is a good option for people who aren't surgical candidates. So someone who maybe is trying to get on the transplant list and is too high risk for surgery. This is potentially a good option for them to get the weight loss they need if they are unable to be listed due to their weight. The downside to this is that there is significant scarring along the greater curve. So you endoscopically plicate the greater curvature of the stomach from the inside with sutures, and that leaves significant scarring. So if someone doesn't have the weight loss that they want after the surgery and they come to me for revision options, a surgical sleeve is no longer an option for them. Their only option is going to be a bypass. The intragastric balloon has gone through multiple iterations. It's a balloon that inflates in the stomach and causes satiety. Temporary results with potential for complications for this. This is all going to be self-pay here. So not commonly used in terms of the true treatment for obesity. And then moving on to medical therapy, you can't go through a day without seeing a new news story on these medications. Did you guys see this article here? This is from the New York Post. America's Ozempic capital is not in New York City or LA, but this redneck southern city. That's Bowling Green, Kentucky. And interestingly, an article came out in JAMA earlier this year, I'm sorry, at the end of last year, that showed for the first time in more than a decade, the mean BMI in the United States decreased from year on end. And I think that anyone who has been paying attention would attribute that to these medications. So that's pretty remarkable. It was a modest decrease, BMI of 30.24 to 30.21, but a decrease nonetheless. I'm not going to tell you guys about these medications and their mechanisms because you know them better than I do, but I highlight that they are very, very expensive, and that's where we are today and where kind of the source of our limited access to them is. I have listed here the total body weight loss that you would expect to see with these medications. And I want to compare those to surgery. So again, I'll draw your attention to these gray bars here, but we're seeing kind of a rivaling or seeing the medications rival the sleeve here. And some of them maybe even approaching the bypass, but definitely the sleeve and easily surpassing the band, the weight you would see after a band. So that's very remarkable. And of course, there are many in the pipeline, as I'm sure you all know. So what does the future hold for bariatric surgery? Yeah.
They're like a cost analysis.
So yes, for bariatric surgery, it's 3 years is the point where bariatric surgery starts to pay for itself. And I want to say that it was 9 years for the medications, but I can't remember off the top of my head if that was true or if like a real true study has been done on that. But
it's more expensive.
Yes, I mean, there's no question. And the question is too, can you ever really come off of them? And that's still, being figured out.
The insurance is paying for this, but they don't want to pay for it.
They don't want to pay for the medications. Yeah.
It seems like after some period of time, the drugs will become generic and then cost would substantially decrease. It's anything like Viagra and those kind of drugs would decrease 100 times or something.
Yeah.
But of course, that's a way off. But still, how might that play into the social run? Get any ideas?
Play into it in terms of bariatric surgery, or play into it in terms of usage of the medications. Yeah. So yeah, that's the big question that everyone is asking. Now that we have these medications, is bariatric surgery going to kind of fall by the wayside? And we don't have the 2023 numbers out, I'm sorry, the 2024 numbers out yet, but they're going to look very different. So bariatric surgery is down about 25 to 30% nationwide, presumably due to these medications. But I think a lot of people expect there to be a pendulum swing back toward bariatric surgery at some point. There are access barriers, which those, of course, are going to improve significantly over time. That's in terms of cost and supply, because the supply issues were really big in this as well. And the reason that compounding, they're still allowed to even compound the medications. But there are a lot of contraindications to the medications. There are very significant side effect profiles. And some people, they don't work. Some people don't lose weight or have minimal weight loss after the with those medications. So that's when I kind of start to see people in my clinic, people who have tried the medications and it didn't work, people who couldn't tolerate the side effects, or people who have a history of pancreatitis and aren't, these medications are contraindicated in them. I see people who don't want to use a medication long term. I compare this to the acid reflux world. A lot of the people who I see for hiatal hernia repairs or for anti-reflux surgery are people who don't want to take a PPI for the rest of their life. And to me, that's one of the most benign medications we could possibly take. There's very weak data on long-term side effects for that, but that's a lot of people who I see in the clinic. They say, I don't want to take these medications. So you can imagine something like a GLP-1 that really does have a significant side effect profile and that we don't really know. You have been using these medications for at least a decade for diabetes, but at lower doses and kind of not in this use and setting. So I don't think that it's really parsed out what the true long-term effects are. And you guys can certainly argue with me on that one. The final, a lot of the people I see are going to be in the BMI 55, 60 range, and these medications are only going to get them so far. So really where we're talking about is surgery versus medical. Why not both? That's where I think a lot of people see this going, and that's where I see this going. Obesity is a chronic condition. We know that. And it's going to take a multidisciplinary treatment approach. So if I see someone who's 20 years old and their BMI is 60 and they want a sleeve, that's great. I'll do a sleeve on them. That's not going to keep their weight off for the rest of their life. It's not going to get them down to where they want to be. And when they're 50 years old, they're going to have a new problem. So what are we going to do then? So the way that people are talking about approaching this and kind of adjusting their practice models is similar to a cancer treatment model, where you talk about neoadjuvant and adjuvant therapy, medical therapy, and where does surgery come into that? Where does revisional surgery come into that? And really putting all of the minds together as a multidisciplinary approach to figure out what is the best treatment option for this person at this time over the course of the next, 60 years. So I think it's a really exciting time. I think it's great that we have the medications. I send my patients for medical weight loss all the time, whether it's before surgery or if they've hit a stall after surgery, or if they have had a bypass in the past and have gained weight. And I say, well, you don't really have a great surgical revision option. I'm going to send you for medical weight loss first. So I'm thrilled that we have the medications, and I think they integrate very well into all of this, and that both fields are going to have a lot of business for a long time to come. As a corollary to that, I would like to advertise the services of the Bariatric Surgery Center downtown. I'm doing the surgical weight loss side. Dr. Lou, who I think most people know here, is going to be providing some endoscopic options. And then Dr. Hiddepol is going to be our medical weight loss provider. And that's really what we're trying to build, a multidisciplinary weight loss center where people can move fluidly between the surgical and the medical side based on kind of what our opinions coming together are for what is the best treatment option for them. So it's really unique. There are not many places like that, particularly in this city or state. And that's really what we're trying to build and our goal. We do have a new location. It's in the multi-specialty clinic, which is in the outpatient center on the 5th floor. We're going to be getting our own space on the 1st floor at some point in time, hopefully sometime this summer. But my phone number is, the office phone number is here. You can put in a referral to weight loss and a referral to bariatric surgery, or a referral to general surgery. If you put it under my name, it will get to me, and I'm happy to talk to people about surgery. Even if they don't know if it's for them, I'm happy to sit down and have a discussion, let them know what I can offer. If they're a good candidate, send them to Dr. Hiddepol if I think they're a better candidate for her, or Dr. Lou if they're a better candidate for him. But we're really trying to provide all of the options and make it very seamless for patients here. So to conclude, obesity is incredibly complex. Our understanding of it is evolving. Bariatric surgery remains the most effective treatment for obesity, and we've taken great strides to improve safety over the past couple of decades. There are multiple treatment options that we have now that are very effective and continue to evolve and improve. And our treatment strategies are increasingly focusing on the long-term treatment of a chronic condition in a multidisciplinary forum. And here's your event code.
Thank you very much,
Yes.
Dr. Bruenderman.
Yes, of course.
One of it is, great overview, especially the newer techniques I'm not so familiar, like SADI and I didn't realize the biliary diversion now is as a longer stretch, because I had one or two. We have a bariatric clinic at the VA.
Yes.
I'm part-time at the VA. And we have a MOVE program, which is an interdisciplinary weight management from the nutritionist, psychologist, and physical exercise physiology. So it's a good program. Earlier, we were referring to the only sleeve person, because I like sleeve and I cannot do that. So was going all the way to Marshall, West Virginia, but now and John Odom here,
Yeah.
and then now I'm beginning to send you
Great.
here. And one thing in the UofL earlier, when you put bariatric, we caught it a little early, but it was sending.
It was auto-populate, yes. I think they have
Yes,
corrected
We have
that.
corrected
Yeah.
that, I hope
Yeah.
so, because that was a big problem. I
Yeah.
actually had to pull the patient back
Yeah.
several weeks later when we caught it. And then a comment on the GLP-1 is that the interesting part about the GLP-1 is all those CV outcome trials, which we've been a part of several of them over the last 15 years. So that sort of adds a interesting aspect to them as opposed to the earlier weight loss surgeries. So pre-surgery, post-surgery weight maintenance, which we do a lot of it at the VA also, is adding the GLP-1 has helped with the CV outcome. The renal now recently has outcome trials and so many
Great.
other aspects, PCOS,
Yeah,
alcohol use disorder, so many different things. So
Yeah.
that's the difference with that.
Yep.
As opposed to previous. So.
yeah, okay, great. Wait, did you have a question?
I know she kind of mentioned what I was thinking.
Okay, all right.
I do have a question, though, sort of like, I've always thought, and I read this in Science 30 years ago, that when you have a weight and you've established a baseline, I also read one time that fat cells fall from more fat, the more fat cells you get, the more they love fat. I read that in Science, but the more interesting thing I thought was that if you can establish a baseline, you tend to go back to that baseline.
Mhm.
And I kind of tell people, well, if you can reduce your calories 10%, you can look for, and then you can hold it at a low weight for a while, then you can realize that you've established a new baseline, you're going to tend to go back to that. So, I don't know if that's actually true. It seems to work for me.
Yeah, so I mean, that's kind of the idea. I think there are a lot of strong opinions on kind of this theory, but it's the set point theory. And a lot of bariatric surgeons believe in that your body has that baseline, that it's your metabolism is going to alter to keep you at that baseline.
It's not always that easy to get back to the baseline.
Right, it's not, yes, but in
it's not
general,
like
yeah.
But you do tend to go back to it.
Yes.
With a little extra work.
Yes, and bariatric surgery, the goal is to change the baseline and make that much lower, so that now when your weight fluctuates, as it will over the course of your life, it's around this much lower set point. So that's people propose this theory that bariatric surgery lowers your set point. It's not been proven. It's a theory and there's data to support it, but to actually prove it, yes, it is. But it's a reasonable hypothesis, definitely.
I have a question, more like a surgical technique question. So if patients had recent fundoplication for severe reflux, and if they wanted any of these, so is there a particular choice of this? You can't change that.
No, you can. So it would be a bypass. So you're talking about someone who had a Nissen and then now wants a weight loss surgery. So you, in theory, would take down the wrap, so restore the stomach to its correct anatomic location, and then perform a bypass, and that will treat the obesity.
Make the reflux worse then?
No, it would improve it.
Okay.
It's an anti-reflux surgery in and of its own right. There are that's the preferred approach. That sometimes that can get a little more difficult, and you can get into the weeds about doing it around, but that's the standard approach,
Okay.
to undo the wrap and then do a
And then
gastric
you-
bypass.
okay.
Yeah.
And my other question was related to UofL's January 1st policy of non-diabetic weight management. And me and Bridget talked about it because we do our own medical therapy, being endocrinology. So
Yeah.
So we don't refer to the medical management part of it, but we struggle. I have a lot of UofL employee patients who are under BMI of 50, and who, of course, are not thinking surgery, although a few of them I've said, please at least go and talk, at least have a conversation.
Yes.
But how are you guys dealing with that part? I know over 50, they agree to surgery.
So,
and there's a
yes.
pathway to use.
And those were kind of cutoffs that we came up with. The concern being that if you have someone who has a BMI of 45, they could conceivably get down to a point where they no longer want or need surgery. And that wouldn't be quite fair, because then we would have to say, well, you can no longer get this medication. And that's not something that I think is right to do.
Yeah.
But it's tough. It's a trend that is citywide, really nationwide.
Nationwide.
Yeah. Yeah. And it's really tough, and we have ongoing conversations about it all the time.
Yeah.
So we are trying our best, and we will see what 2026 has to come, but it's certainly something that we hope we will be able to provide to UofL Health employees. It's just kind of the culture right now, and hopefully as rebates come in and the medications get cheaper, I think that everyone wants to cover the medications. It's just from a financial standpoint, it's really, yeah, it is. I mean, it's to the tune of millions of dollars, so it's a hard time.
Yeah.
Oh, yeah, I got one more question. Now, on last Thursday, Dr. McLean was talking about some of these medical things.
Mm-hmm.
And he was saying that something about people losing protein, losing a muscle mass.
Yeah.
And then on the medications, and then that doesn't come back. Now, when I used the interpret, and I wanted to say something else, but regarding that, when I used to interpret the electrophoresis, I found that sometimes people would have a low total protein, and if they weren't losing it in the urine and they didn't seem to be losing the gastric system, I would invariably go to the record and find that they have some kind of bariatric surgery. And of course, protein is related to muscle. So, and I'm wondering if you see the same thing with bariatric surgery.
So yeah, our post-operative protocols really hit protein very hard, because we know that that's something that happens. So at least 70 grams of protein, I tell for it, which is really hard when your stomach is the size of a hard-boiled egg, but that's their main macronutrient. And I hammer that every single time I see them. I want to know how much protein they're getting. There are a lot of bariatric surgery products for bariatric patients to get the protein that they need. And then strength training. That's something I start harping on them at pretty much their first post-operative visit of your muscle, or your weight loss needs to be fat and not muscle. And these are the things that we need to do to prevent that. So it's interesting, because these are kind of standard protocols with bariatric surgery, because we know that that's a complication that can happen. And now that we have medications that are leading to such great weight loss that we've never had before, there aren't these formal processes in place for most people to address that. So that's something we're certainly hoping to do here, to have the nutritional component with this and say, this is what you need to be doing to make sure your weight loss is fat and not muscle. But that, all of these places where you're going to go, the, Weight Watchers and, all these weight loss centers, they're not going to have these protocols in place typically. Yeah, it's just
questions.
Yeah,
There are a
so
couple of questions
there's
online.
will removal of a significant portion of the stomach to get rid of malignant gastric neuroendocrine tumors have similar effect as bariatric surgery in an obese person? It depends on where that's located. So the biggest thing that you need to get is the fundus to have the greatest weight loss with this surgery. Once you get down to the antrum, that doesn't make a difference in terms of the weight loss. So it's going to depend on where that's located. But yes, it will. And that's one of the reasons that people kind of started noticing that this was an option to help people lose weight, is because they were doing those types of surgeries and noticing that people were losing weight after them. So that kind of spawned this entire field. And then are there constipation problems after bariatric surgery with the sleeve and the bypass? Yes. So I start patients on Miralax every day for the first month at least after surgery. But oftentimes I'll see people in my clinic who have problems after surgery, severe abdominal pain, et cetera, and it's because of constipation. Even if they're having regular bowel movements, if you get a CT scan on them, they will be chock full of stool all the way up to their cecum. But for the duodenal switch and the sati, that it's going to be diarrhea and not constipation typically. And then, are there any examples where bariatric surgery in young individuals improve the pregnancy outcome or improve reproductive health in men? Yes, a number of the patients who I see will be for reproductive issues specifically. One of the things that I counsel patients on after the surgery is that their fertility will skyrocket. And so I recommend 2 forms of birth control. I want to know what every single female in my program is taking for birth control, because fertility will skyrocket after the surgery. And there have been plenty of oopsie babies and plenty of people who have actually had success with pregnancy much later in life, even though you would expect, but it was because they had weight loss from weight loss surgery.
Actually, it's 1 year, right? You have to wait.
I say 18 months. Yeah,
18.
18 months before I recommend pregnancy.
Do you always
Okay.
do you do vagotomy with the procedure or not?
No, no vagotomy for it. I mean, you will cut through the vagus nerve in a bypass, as you kind of have to, but no vagotomy.
Okay.
For refractory marginal ulcer treatment, some people will do a thoracic vagotomy, but that's kind of getting into the weeds.
So are most of the surgeries sleeve?
Are most weight loss surgeries what?
Sleeve?
Yes, that's the majority of the surgeries in 2024.
Okay. Well, thank you very much. If there are no other questions,
Thank you, everyone. Please let me know if you have any
Right.
questions or problems referring people or anything like that. I'm happy to answer and
They
happy to
usually
help.
just surgical part.
Okay.
Or if the patient wants to see Nathan, then I just
Sure.
talk to Nathan.
Yeah,
directly.
yeah. He's gonna have 1 day per month or 1/2 day per month, I think, starting in March.
And Bridget is there twice.
Twice a month,
At
yeah.
least.
Yeah.
That's great.
Yeah.
Yeah.
So we're slowly but surely getting it done.
Thank you. That was
Thank
very.
Good.